Hello, this is Dr. Wendy Thompson, and I will be presenting today on policymaking and politics. And I'll be approaching this topic from my public health background. Policies are rules for collective life. The health of the community requires a community-wide responsibility. Policies are authorized by people, usually determined by consensus. Strategies include citizenship skills, community organizing, advocacy, lobbying, and legal tactics. Once implemented, policies are enforced by authority. Sometimes nurses state that they're not involved in policy making. So I would really like to challenge that concept because in my view, anytime a nurse is involved with determining how a procedure or a process is to be carried out with other professionals, they are involved in policy decision making. The definition of a mandate is the authority to carry out a policy or course of action. Public health mandates are defined by population rates. From 1999 to 2009, the age-adjusted death rate in the United States declined from 881.9 per 100,000 population to 741 per 100,000. A record low and a continuation of a steady downward trend that began during the last century. It was changes in policy in public health that contributed significantly to this decline. Measures that bring the benefit to the population bring small benefit to each participating individual. This is a graph that shows the attributable risk in a population. The blue line represents the risk. The green line represents the population. You can see that the population is represented within the bell curve of the green line. You can see that there are less people at the extremes of no risk and extreme risk. The person who would fall the farthest to the right is the highest at risk, and their personal risk is serious. One example might be serum cholesterol. The goal is to move the whole distribution to the left so that the whole population moves. More cases are in the middle of the distribution. These are the people that we want to affect and be concerned about with policy changes. Notice that when the population moves to the left, even the tail will move. Therefore, those that have the highest risk have decreased risk if the whole population improves their risk. It is important to understand that strategies developed for individuals that are at the highest risk will not change population rates, but will only focus on changing the highest risk individuals and will have minimal impact on those highest risk individuals. Therefore, strategies such as policy development are directed to the population as a whole. As stated by Jeffrey Rose, small changes in a large number of people produce greater benefit than large changes in a few. Think about the impact of no smoking policies in public facilities. The impact has been profound to the population as a whole. The Freedom to Breathe provisions amended the Minnesota Clean Indoor Air Act to further protect employees and the public from the health hazards of secondhand smoke. The Freedom to Breathe amendments became effective October 1st, 2007. This graph shows the decrease in the exposure to environmental tobacco smoke after the implementation of the Freedom to Breathe Act in 2007. Exposure in the community is measured by the following survey question. In Minnesota, in the past 7 days, has anyone smoked near you at any place besides your home, workplace, or car? Social practice reflects the social norms no matter what the individual choice is. The social norms in populations are predictable and endure over time. The status quo is the norm and is difficult to change as people are comfortable with what they are used to. One example of a social practice or mass phenomenon is the amount of drinking alcohol sold at the Twins games. Based on the number of individuals in attendance, they can predict with great accuracy the amount of alcohol that will be sold at a game. Even when the policy was changed to not sell any alcohol after the 7th inning, the same amount of alcohol was sold as had been the social practice prior to the policy change. The policy change may have only impacted the degree that the alcohol influenced behavior at the time of departure from the stadium. Yeah, it's such human nature for us to stick with the status quo. So here is a list of the characteristics of regulatory policy. The focus is to do what works, and the emphasis is on the product as people are more unreliable. The policy assumes human frailty, and this regulatory policy looks to break the link between the agent, host, and environment. This shows the continuum of policies for the protection of using safety devices for driver protection. The first level is knowing that seatbelt use could save your life. Even if people are aware that safety belts save lives, it doesn't not necessarily get them to change their behavior and buckle up. The population is more likely protected by engineered airbags and automatic seatbelts. The strategy of engineered airbags did greatly impact the degree of injuries and the death rate from automobile collisions. In the case of changing the policy for required seatbelt use, the new law or mandate was based on population rates of fatalities related to motor vehicle collisions. The law was first suggested and placed in law as voluntary, then enacted or mandated with no enforcement, and after a few years, it was changed to the social norm to wear seatbelts. The law then was completely enforced. The difficulties with policy change is that there will always be some potential unintended consequences. We can use the seatbelt policy as an example. You probably have heard stories where someone was saved because they did not have their seatbelt on, or that there was a death because of a seatbelt. Often, new policies can be difficult to evaluate, and it is important to have a plan for evaluation prepared prior to making a change. In the case of the Freedom to Breathe Act, the Minnesota Department of Health planned an evaluation of testing those that were employed in the food industry for levels of tobacco exposure before and after implementation. This was a very impactful as they could show by their evaluation huge significance in the amount of exposure for employees who worked as waitresses in the food industry. One can see the difficulties related to the change in policy related to coronavirus. Because of the nature of the pandemic, it is difficult to plan for evaluation, leading to many interpretations of the efficacy of social distancing. Always, something that changes the status quo is automatically controversial. People are comfortable with the status quo, and forces want to maintain the equilibrium of the status quo. Reflect on the changes that you have tried to implement in practice. What were the difficulties that you encountered? Could you have developed a better plan for evaluation of the change to make the change in practice go more smoothly? Policymaking is the determination, development, and administration of public policy to protect and promote the health of the public. There is policy development at all three levels of government. At the national level, examples of institutions that establish policy at the national level are the Social Security Administration, the Health Care Finance Administration, and the Public Health Service. Under the 10th Amendment to the U.S. Constitution, all powers not granted to the federal government are reserved for the states and the people. Therefore, the bulk of policy is formed at the state level. Public health examples include immunization laws, water quality, and funding for programs. Often, the state is required to provide oversight of national health policies to the local level. Implementation of the policy changes related to social distancing related to the coronavirus pandemic is an example of state oversight.
Policies are also established at the local level to protect and promote the health of area residents. Often, implementation of evidence-based policies and interventions occur at all levels by federal, state, and local public health authorities. This approach has had significant impact on many public health initiatives, including tobacco use, the control of infectious disease, maternal and child health issues such as neural tube defects, motor vehicle safety, and cardiovascular disease prevention. These are just the tip of the iceberg, the very few examples of some of the health care policies that are in place. A policymaking model can be useful for you to better understand and engage in policymaking. Developing health policies can be complex. The Kingdon and Longus models are used to understand and engage in policymaking. Here we will compare the Kingdon and Longus policymaking models. The Kingdon model uses a multiple stream approach to policymaking. It is based on 3 separate streams identified as problem, politics, and a policy coming together during a moment in time or a window of opportunity that creates a change in policy. It begins with identifying a problem that is then shared amongst policy committees. Within the committees are specialists that produce proposal drafts and debates. The Kingdon model centers on ideas becoming solutions to policy problems. In contrast, in the Longus model, policy making is approached in a cyclical process in which laws are subject to change. This model emphasizes the power that individuals, organizations, and special interest groups have on every aspect of the process. Laws are modified from other existing policies. This approach tends to make more incremental changes again and again. An important aspect of policymaking models is that they need to consider the health impact of policies on the citizens. I will look more specifically at the history of the policies created by local boards of health in Minnesota. In 1872, policies were created around assessment of health, limiting the spread of communicable disease, and assuring sanitary conditions. These same policy areas are still in place in present day, but we know that they have been changed significantly since 1872. You can see that investigating and controlling communicable diseases as well as assessing the health of community has always been a requirement of the local board of health. The changes in 1976 provided more structure to the governing board and provided better guidelines to the local government on preparing a community health plan. The Community Health Board is the legal governing authority for local public health in Minnesota, and community health boards work with the Minnesota Department of Health in a partnership to prevent diseases, protect against environmental hazards, promote healthy behaviors in healthy communities, respond to disasters such as a global pandemic at the local level, ensure access to health services, and assure an adequate local public health infrastructure. One of the 1976 requirements that was passed determined that there needed to be a minimum population of 30,000 in order to be eligible to be a local board of health. This dramatically changed the number of local boards of health across the state of Minnesota. Minnesota's public health system functions as a partnership between state and local governments, is regarded one of the best in the United States, and is designed to ensure that the public's health and safety are protected statewide while providing local governments with the flexibility needed to identify and address local health issues. Both levels of government have statutory authorities and responsibilities. You can see prior to 1976 that there were more than 2,100 local boards of health in Minnesota. And can you imagine being the Minnesota Department of Health and trying to coordinate and plan for care across the state while working with 2,100 boards of health? Once the policy change took place in 1976, that drastically decreased to working with less than 50 boards at that time. And currently there is 51 boards of health at the local level in Minnesota. Politics are a reality in policymaking. Therefore, I will conclude this presentation by looking at effective characteristics of governing boards that are responsible for public health policy. The board's attention should be on values rather than the specifics of implementation. The board's greatest concern is about long-term effects on specific areas of need. The board's attention should be on the ends as opposed to the means. How is our community to be different because of our mission? The board powerfully delegates to optimize executive performance, the one who is the expert on the content and leads the organization. The board should rigorously monitor executive performance, but must relax about the present in order to get on with the future. The board needs to be aware of other community undertakings as they identify with and communicate with groups and organizations within the community. And finally, boards are more connected to their constituents that place them in office, and they need to remain open to their community on decisions that need to be made in regards to healthcare policy.